All right, good morning, everybody. Thank you for joining us with this combined radiology and ENT meeting. A very special thank you to our radiology colleagues, Dr. Ahmed and the team, for joining us this morning and participating. So this morning we're going to be presenting, excuse me, 4 case presentations. So the format will be, I'll present the cases. We'll go through the case history, the presentation, examination, and a few specific investigations. And then we will allow our radiology colleagues to show us and go through the imaging. And once we're done with the imaging, we'll just go through what the diagnosis is and also what just a brief history on the management. And then we'll proceed to the following case. All right, so let's start. Just some disclosures. The consent was obtained for use of the patient's clinical data for this presentation, and there's no intent for copyright infringement. So let's go to case 1. So we've got patient LL, it's a 15-year-old male, presented with a 1-day history of headache, lethargy, fever, vomiting, and left-sided otorrhea. It's got a background history of autism with speech impairment, epilepsy, and also has a history of bilateral intermittent chronic otorrhea, was being managed at the day hospital for this. In clinical examination, the only thing to note is that he was confused with a GCS of 14 out of 15. He was lethargic. He had some neck stiffness, but there was no mention of meningism, but he had no other focal neurology, and cranial nerve examination was normal. On ear examination, he had no obvious post-auricular swelling. His right ear, however, was quite wet with a mucopurulent discharge and squamous debris. His left ear was not discharging, but there was noted to be an attic polyp with squamous debris. Just highlighted some of the important investigations. His white cell count was 16.52, and LP was done. And as you can see, he had 31 polys, 19 lymphs, and 14 erythrocytes. He was diagnosed with a bacterial meningitis. I'll allow my colleagues to, I'll stop sharing now.
Thank you. Morning, everyone. My name is Jume. I am one of the radiology registrars in Groote Hospital, and I'll be presenting the case with my consultant, Dr. Ahmed. Screen share. Can you see my screen?
Yes, yes, okay. We can.
So the patient initially presented to Somerset Hospital, had a CT scan, contrasted CT scan on that side. I'm just going to show you the bone window on coronal plane. You can immediately see that there is opacification of the proximal external auditory canal extending into the middle ear cavity and into the mastoid air cells. Also of note that there is bone erosion of the articular chain, as well as the scutum, and the tympanic membrane was not seen as well. Then moving immediately, we can also see that there is impression of the dehiscence of the wall of the lateral semicircular canal with gas locules. Let me just try and window this down. With gas locules in the within the vestibule and within the semicircular canals. There is also bony break or dehiscence of the tegmen tympani. Then just want to show you the facial nerve canal. Just going to go on axial. So this is the labyrinthine segment of the facial nerve canal as you're coming down you can see that there's dehiscence of the lateral wall of the tympanic facial nerve canal. Otherwise, the mastoid segment is normal and exiting at the skull base. Then back to coronal plane. We can also appreciate that there's intracranial free gas locules lining along the temporal bone and extending into the subtentorial space. So on the contrast study, we can appreciate the sliver of subtentorial subdural collection that is associated with these gas locules. And the collection, just a sliver, measures about 4 millimeters on axial plane, and it's starting to cross the midline to the contralateral side. Otherwise, there is also diffuse cerebral edema. You can see that there's loss of normal surface sulcal markings up in the vertex, but the gray-white matter differentiation is still preserved. The ventricular profiles are also quite prominent it was suggested there might be a degree of hydrocephalus, but the patient did also have a CT brain earlier on in 2011, and the ventricular profile hasn't changed. So I think this is the baseline for the patient. And then there's no dural venous sinus thrombosis as a complication. So in summary, because of the extensive underlying bone erosions, we thought this underlying cholesteatoma is thought likely, and it's complicated by intracranial collections and cerebral edema, but there's no dural venous sinus thrombosis. And then I just forgot to mention that on the other contralateral side, there is also less degree of the disease on the right side. We can see also complete opacification of the middle ear and mastoid air cells, but the oscular chain still remain intact. Then 2 days later, the patient had a repeat CT in Krzyzewski Hospital just to follow up on the subtentorial subdural collection, which has increased in size from 4 millimeters to 7 millimeters. Again, no dural venous sinus thrombosis. Then 5 days later, after the initial presentation, there's further increase in size of the subdural collection. You can see it definitely crosses now to the contralateral side. I think at this time it measures approximately 13 millimeters. Then patient then subsequently went for neurosurgical intervention. You can see that there is a left occipital craniotomy with surgical emphysema from the surgery, but just when going down to see the collection, there is no change in size. Well, there is persistence of this subdural collection with the increase in size of this component on the left side. Then our last CT showed that the patient had, sorry, it's a wrong study. Let's close this one. So then the patient had bilateral mastoidectomies. So this study was done on the 30th of August, which is about 2.5 weeks after the initial presentation. And so bilateral mastoidectomies, and I think there was also drainage of the subdural collections. We can see that there's complete resolution of the subtentorial collections. Thank you.
Thank you. You can stop sharing your screen.
All right.
Thank you. Okay. So the patient was diagnosed with a bilateral cholesteatoma with an acute left mastoiditis, which was complicated by a subtentorial collection, as well as cerebral edema and a pneumocranium. Just briefly on management, he was continued on IV ceftriaxone and metronidazole. He initially had a left cortical mastoidectomy by ENT, subsequent to his admission. It was decided at that stage by neurosurgery to treat the patient conservatively for the intracerebral collection. However, he continued to spike temperatures and 2 days later had a craniotomy with the neurosurgeons. Just a brief thing on aspirates, just showed gram-positive cocci. The culture was negative after 3 days. And then on the same admission, about 8 days later, the patient had a left canal wall down tympanomastoidectomy and also removal of that attic cholesteatoma with the right atticotomy with the ENT. And patient is doing well now in the ward.
Shavina, I just wanted to quickly come in here. I just wanted to say that the imaging of the ear would have been best by means of a cone beam CT to see the features of the cholesteatoma much better.
Okay, thank you, Dr. Ahmed. All right, let's go to case 2. So here we've got a 46-year-old female. She presented with a 4-month history of right-sided facial pain and headaches, with a chronic history of nasal congestion and hyposmia. She is a non-smoker, no alcohol history. The background is that she is hypertensive. She's asthmatic with allergic rhinitis. She also has rheumatoid arthritis, is on disease-modifying medication. She's on methotrexate for that. And she's also got vitiligo. On examination, initially, the flexible nasoendoscopy didn't show too much. She just had bilateral nasal congestion with a grade 1 right nasal polyp seen. Otherwise, the rest of the nasal cavity and postnasal space on the notes is clear. On CNS examination, the only thing to note is that she had fallout of a trigeminal division 1 and 2 on the right side of the face. Otherwise, the rest of the examination was normal. And then also just to note, she had generalized vitiligo. Investigations, there was not much to show. We did a brief workup for autoimmune, looking at potential vasculitis versus Wegener's granulomatosis, and those tests were negative. All right, I'll stop sharing my screen. Can you share your screen?
Thank you.
We can see your screen.
Thanks. So the patient initially presented to Mitchell's Plain Hospital, where she had a post-contrast CT study. So just going to the area of concern, we can see that there's immediately this poorly heterogeneously enhancing mass centered in the pterygopalatine fossa, extending superiorly into the ethmoid sinus, as well as with intraorbital extension. Just coming a little bit lower down, the patient also, the mass also extends immediately into the posterior nasal cavity, and also into the sphenoid sinus here. There's also extension into the middle cranial fossa. You can see that there is this mass protruding into middle cranial fossa via the eroded sphenoid wing, which I will show you in bone window. So bone window, you can see that there's expansion of this pterygopalatine fossa. There's also erosion of these posterior medial aspect of the right maxillary sinus wall, as well as the right laminar papyracea, and also the right sphenoid wing, and also the pterygoid body, and the anterior lateral aspect of the right sphenoid sinus wall. You can also see that there is remodeling of the bone into the clivus. Then again, this post-contrast study, I just want to show you on coronal plane. So again, you can see this mass extending into the orbital cavity, where you can see that there's loss of normal fat plane between the medial and inferior rectus muscle. And this is extending via the bone erosion of the laminar papyracea, extending inferiorly into the maxillary sinus. And then you can see this is the eroded sphenoid bone, and there's early extension into the middle cranial fossa. Rest of the brain is unremarkable, and there's no duodenal sinus thrombosis, and particularly there's no cavernous sinus thrombosis. So in summary, just from the CT scan, there is aggressive sinonasal mass with intraorbital and intracranial extension. Our differential diagnosis included primary sinonasal malignancy or possibly chronic fungal sinusitis due to the bone destruction and lack of expansion of the sinuses. Then the patient had a MRI study at Krzyzewski Hospital about 3 weeks later. So this is a T2 weighted sequence. You can see that there is this hypointense mass centered in the pterygopalatine fossa, also involving immediately into the posterior middle nasal cavity, extending anteriorly into the maxillary sinus, and then superiorly again into the ethmoid sinus, and then into the orbital cavity, and posteriorly into the sphenoid sinus. Difficult to appreciate the intracranial extension on this MRI sequence, particularly that this is a thick slice. Just want to show you the pre and post contrast on T1 weighted sequence. So on top, we have the T1 weighted fat sats in coronal plane. This is pre-contrast and this is post-contrast. We can appreciate this is a poorly enhancing mass, again seen in the sinonasal cavity or region, with extension into the orbit, nicely appreciated on the coronal plane. Then just want to show you the intracranial extension on this. I think this is the intracranial extension into the middle cranial fossa. Just want to go back to the T2. Forgot to mention that the mass laterally, the mass also extends into the temporalis muscle, as well as extending into the lateral body of the lateral pterygoid muscle. And this high T2 signal intensity likely suggests edema. There's also complete opacification of the right maxillary sinus, well, actually of most of the paranasal sinuses, with T2 hypointensity centrally. And the rest of the brain was normal. So in summary, we have this aggressive posterior nasal tumor or sinonasal tumor with sinus and intraorbital extension, and as well as intracranial extension, also with secondary obstructive sinusitis. We've got 3 differential diagnoses. So the first would still include the primary sinonasal malignancy. Second is that this location is typical for inverted papilloma, possibly with malignant transformation, although we don't have the typical imaging features of that cerebriform signal intensity. And then the last top differential would include the granulomatous invasive fungal sinusitis. However, this lacks the homogeneous intense enhancement on post-contrast study. Thank you.
Before you stop sharing your screen, can I ask, on MRI, what are some of the features that we can look at with regards to an invasive granulomatous fungal sinusitis? And is it best viewed on a T1 weighted or a T2 weighted?
So with invasive granulomatous fungal sinusitis, it can also has similar imaging features of the chronic fungal sinusitis. So it typically it's typically large with expansile mass, and they typically destroy the bones and have local invasion. And then on CT, they're usually hyperdense with homogeneous contrast enhancement. And then MRI, they're usually hypointense on T2, but they generally have intense homogeneous enhancement. Yeah.
Okay. Thank you. You want to stop sharing your screen?
Should I stop straight? Okay.
Okay. So this patient was taken to theatre. She had quite an extensive endoscopic sinus surgery. She had a frontal sinusotomy, had a wide maxillary antrostomy, as well as an anterior and posterior ethmoidectomy with partial removal of the lamina papyracea, and also had a sphenoidotomy. She's diagnosed with an invasive granulomatous fungal rhinosinusitis. Initially started on empiric oral augmentin post-op. It's also reviewed by infectious diseases and empirically started on voriconazole for an Aspergillus species. We are still at this point awaiting microbiology cultures to identify what type of fungal sinusitis we're dealing with. Just some histology feedback and just with regards to the suspicious non-benign changes on MRI and CT. It was negative for malignancy. We also did a Zeal-Nielsen stain, which was negative for acid fast bacilli. And then the fungal stains came back positive, confirming fungal hyphae and fungal elements. And was consistent with the granulomatous invasive fungal sinusitis. Like I said, we're still awaiting microbiology cultures, as well as TB cultures for this patient. So at this stage, is there any questions regarding this case? I don't see anything on the chat. Okay, all right, so we'll continue on to case 3. So this is a 23-year-old male, presents with a left-sided facial mass in the cheek. He is a known patient with neurofibromatosis type 1. He's also got hypothyroidism. He's also got, he's mentally challenged, also with a background of scoliosis. Interestingly, in his past medical background, he had a left parotidectomy at the age of 8 years old for a left plexiform neurofibroma of the face and neck, and was initially being followed up by us for that. He unfortunately developed a Fraser syndrome over the left side of the face. We offered him at this point Botox injection, and that was in 2018. And he had some improvement in his statutory sweating, but still had a small spot on the left parotid area of sweating. So on examination of this left facial mass, he had left facial asymmetry with quite a large fullness in his left cheek. It was a soft mass. There's no overlying skin changes. He's known with, he also has multiple cafe-au-lait spots all over the body. No cervical lymphadenopathy noted. On cranial nerve examination of significance, his facial nerve was intact on the left side. And the rest of his cranial nerve examination was normal. Oral examination, he had no trismus noted, and then he had a normal oral cavity. So initially, we were surveillancing the left mass. We did note that the mass had now increased in size, and we decided to do a core needle biopsy, which was unfortunately not representative of the mass. And we went on to do some imaging. Right, I'm going to stop sharing my screen.
Thank you. Okay, so I just want to show you the index imaging that we have on our system. So the initial MRI was done in 2007. This is a T2 weighted sequence in axial plane. You can immediately see that there is this large hyperintense mass centered in the left masticator space. Anterior immediately infiltrates into the masseter muscle, and then posteriorly involving the superficial lobe of the parotid gland. You can see this is the normal right parotid gland, and this is the left side. So this is before the removal of the parotid gland. Then just of note that you can see that there's this sort of oval-shaped or round-shaped configuration of these lesions with the central, some of them have the central low signal intensity dot. And this is radiologically in keeping with the target sign that is quite pathognomonic for peripheral nerve tumor or neurofibromas rather. Difficult to see the other ones. I think there's some movement artifact. Then just going to go to the current study, which was performed on the 13th of July, 2020. So this is the initial study on top, and this is the current study. You can immediately see that there's a big size discrepancy. So initially, this was measured 3 by 6 by 6 centimeters. Currently measures 5 by 8 by 7 centimeters. Again, you can appreciate this target sign typical for neurofibromas. So now the mass extends more anteriorly, again involving the masticator space, and then posteriorly into the thought to be the parotid region, because the parotid gland, I think you said it was removed. Then this mass also appears to erode into the zygomatic arch. You can see the normal side on the right, but there's infiltration into this, onto this side. Just want to show you pre and post contrast study. So this is a T1 weighted pre-contrast and post-contrast study, which can see that there is heterogeneous avid enhancement of this mass. Again, you can see, or you can appreciate that there's erosion of the zygomatic bone. And then posteriorly eroding into the parotid space. So I think the question was whether there was also a facial nerve involvement. So the cysternal segment of the facial nerve was definitely not involved because not in that location. To show you on T2. So this is the cysternal segment of the facial nerve. However, the extratemporal segment or the superficial branches usually arising from the anterior aspect of the parotid gland. So because of the extensive infiltration into the parotid region, we thought that at least the origin of these branches are thought to be involved. However, we don't have the high resolution MR study to clearly demonstrates the facial nerve. So we had to assume that there is involvement of the origins of these superficial branches. So in summary, there is increase in size of this known plexiform neurofibroma. Radiologically, I think there is concern for malignant transformation as it is bigger than 5 centimeters and there's local infiltration into the zygomatic bone as well. Thank you.
Are there any questions regarding the imaging?
Shavina, I just wanted to say, so the imaging basically, to look at the facial nerve is suboptimal. What we need is high resolution 1.5 Tesla MRI scanning or 3 Tesla. And you need specific pulse sequences included with, you need to include DWI as well. So just because of the size of this thing and where we thought that the terminal branches of the facial nerve are coming from, which would be from the anterior border of the superficial part of the parotid gland, we assumed that those branches would somehow be involved. But on these thick slices, we cannot see those branches. Thanks.
Sorry, Dr. Ahmed, I think we lost you there for a second.
Sorry, did you hear any of that?
We heard most of it.
Okay, yeah, sorry. So I said, so on these slices, we aren't able to give you that information because the imaging is suboptimal. Thanks.
So would you suggest if we are going in to excise the mass that we first do further imaging just to get an idea if those branches are involved?
Yeah, I would expect, I mean, from the size of this thing, and I mean, I speak under correction. I think surgeons probably know better, but I'm under the impression that the terminal branches come off once the facial nerve exits the parotid gland. And looking at the size of this mass and the location, I would probably expect that most of them are involved.
Okay. So we have, since that image, repeated the core needle biopsy. And the histology came back as a neurofibroma with a myxoid change. They don't mention any malignant change in the biopsy results. So at this point, the patient is awaiting a follow-up with us at our OPD. And there is a question as to whether we need to do a surgical excision with a facial nerve graft for this patient. However, I do think we should probably do some further imaging to just understand a little bit better if those branches are involved or not. Any questions regarding this that case before we move on?
Shavina, it's Matthew. Can I ask the radiologist just a quick question, or to just reiterate, in these neurofibromas that they spoke about a cut-off side as well as obvious local invasion, are there any other features, or can they just re-mention to us what features would make one concerned that there may be underlying malignant transformation?
As we said, if so, increasing size in mass of the size of the mass, and obviously the bony erosion, I think is probably one of the features that would probably suggest that there's malignant transformation.
Yeah, thanks.
Okay. Right, let's move on to case 4. This is our last case. So we've got a patient who's a 46-year-old male. He presents with confusion and a right-sided otalgia with a mucopurulent otorrhea and quite an extensive right-sided neck mass. It was also noted that he's day 10 post-tooth extraction, and he's got a history, he's got poor visual acuity, quite dense cataracts, and he is mentally challenged. Initially was seen down in C15, and which is our emergency unit, and diagnosed as a deep neck space abscess. On examination, when we saw him, the ear examination, the right ear was quite wet with large polyps occluding the external auditory canal. His left ear was otherwise fine. On the neck examination, he had quite a massive right neck abscess anterior to the sternocleidomastoid muscle, and extending through levels 2, 3, and 4 from the right sort of margin of the mandible all the way down to the right clavicle. Quite a large mass. Otherwise, the patient was apyrexial. He didn't have any airway issues, but it was noted that he had a GCS of 14 out of 15, so he was a bit confused. And then he had no focal neurology, and his cranial nerve examination was normal. Just some investigations we did to note his white cell count was quite elevated at 22.8, and as well as his CRP, which was 342. We also did an LP down in the emergency unit, and he had quite a lot of cells in his fluid, and was also diagnosed with a bacterial meningitis. I'll stop sharing my screen.
Thank you. So the patient had only one imaging done in Chris Sisky Hospital on the 18th of July this year. This is a post-contrast study of the brain and neck. Let's window it down. So you can immediately see that there's a striking abnormality in the right side. There's extensive hyperenhancement, also with underlying fluid collection. So the fluid collection arises from the right middle and mastoid air cells, middle ear cavity and mastoid air cells, and extends into the external auditory canal and with abscess extending into the pinna, also posteriorly involving the post-auricular region. There is severe destruction of the right temporal bone. Let me just show you on bone window. So extensive bony destruction of the right temporal bone, as well as the mastoid air cells and also the ossicular chain, where you can see that there's near complete erosion, bone erosion. The collection extends through this eroded temporal bone into the sigmoid sinus. Furthermore, that there is also this filling defect or collection extending to the jugular foramen, and then going down, you can see this irregular rim enhancing fluid collection extending all the way to the supraclavicular region along the carotid, a deep carotid space. The internal jugular vein so going from the SVC here, then there is the brachiocephalic vein. This is the right subclavian vein. And as you're coming up, you can see that there's abrupt tapering and cutoff of the proximal internal jugular vein. And then you get this collection. Sorry. And then you get this collection. So to us, by imaging, we thought that the internal jugular vein is compressed. Difficult to say whether it's thrombosed as well, but definitely compressed, extending all the way into the jugular foramen here. Then just complication of with the transverse sinus thrombosis. You can see there's filling defects. I can show you on the coronal plane. So you can see that this transverse sinus is well pacified with contrast. This is the right side. You can see that it's expanded with internal filling defect, suggesting secondary duodenal sinus thrombosis. Then just to come to the mass effect. So there is leftward displacement of the pharyngeal structures with mild narrowing of the oropharynx as well as the laryngopharynx, but no tracheal narrowing. Then in the lung window, even though there's movement artifact, but there's no trine bud nodules or cavities. So in summary, we have a right automastoiditis with associated mass effects, now complicated by local and deep neck collections, as well as duodenal sinus thrombosis. Thank you.
Are there any questions? Don't see anything on the chat. I can stop sharing. Thank you. Okay. So the patient was diagnosed with an acute right mastoiditis complicated with a Bézos abscess. Initially had a right cortical mastoidectomy and incision and drainage of the right neck abscess. Patient was continued for 10 days on oral Augmentin, and was discharged on day 14 post surgery. We then brought him back about 2 weeks later for definitive ear surgery. He had a right canal wall down mastoidectomy and cavity obliteration, and there was no reaccumulation of the right neck abscess. Right, so
Shavina, I just wanted to ask something. So from the imaging, how do I share?
yes.
Oh, can you stop sharing? Can you stop sharing and then we'll share?
No problem.
So what did you people find regarding the internal jugular vein on that side? Because the reason I'm asking is if you follow the sinus into the jugular vein there, into the jugular fossa over there, that looks aurum enhancing. And then if you follow that out, that's continuous with the rest of this abscess here in the neck, right? So is this internal jugular completely compressed all the way through? That's why I'm asking, what did you find? Because we could only see it right at the bottom, at the base of the neck, coming from the chest.
Hi, Dr. Ahmed. It's Simon. Did the initial surgery of the IND of the abscess and the cortical mastectomy. We didn't explore the internal jugular in the acute setting. It's not usually policy. We would just do the incision and drainage of the abscess, trying to break down all the loculations, and then he wasn't symptomatic of any internal jugular obstruction, so that's we just left it at that.
Okay, thank you.
Thank you, Dr. Ahmed. Are there any more questions regarding any of the cases before we end the meeting? Just having a look on the chat. There are no questions.
Sorry, I just wanted to contribute one comment in that may I, Nazir?
Yes, you may.
Yes.
Yeah. You see, vagus is now called granulomatous with polyangiitis. I think that's a new terminology that they're using internationally. So I think we must follow the international terminology if possible. Thank you.
Thank you for that comment. Is there anybody else? Okay. There's no more questions. Thank you again, Dr. Ahmed and the team for contributing to this meeting. We do appreciate your time. Thank you to everybody else that joined us this morning. We will now conclude the meeting.